My whole life, my father told me stories about moving to the United States. He would tell me that his brother, my Uncle George, was already living here and let my father stay with him for a while. Through my Uncle George, my father was introduced to our cultural organization here in America, who helped him make connections, apply for college, find his first job, and adjust to life in a completely different culture than he was used to. The Cultural Association helped him get started on his new life. My Uncle George would bring my father with him to the annual Summer Cultural Groups Festival, and later, he would bring me. It was incredible to see so many people of all ages laughing and celebrating with food and song and dance. It brought back the best feelings of home and gave my father the opportunity to pass his culture, language, and values on to me. My father and Uncle George were very close, so when George died last year, my father wanted to honor his wishes to be buried with a traditional ceremony back at his birthplace. My father told me that because Uncle George had cultural group life insurance, he was able to afford to bring George home and have the traditional burial George wanted. Though my father had been able to honor my Uncle George's wishes, it got me thinking about my own family. One day, I'd have to make the same arrangements for my own parents, and my wife's parents as well. Of course, we would want to bring them home and honor their wishes, but it would be a financial hardship for our family. There were a lot of things to think about, even though I really didn't want to think about them at all. When my father told me about cultural group life insurance, he told me it's intended to help families when they need it the most. It's not tied to an employer, so no matter where my career takes me, I'll always have coverage. The more people who participate and the younger they are, the more it helps keep the insurance premiums down for the entire association. Because my parents have cultural group term life insurance, there will be money available to help me provide the kind of service I want to give my parents. And by joining, I can put my mind at ease and continue to celebrate our traditions into the future. With cultural group life insurance, I can worry less and spend more of my time celebrating with the people who matter most to me.
Good evening, this is Bolo. Welcome back to our monthly show on health and wellness and social justice issues. Today, the topic that we're going to have today is about Black women's mortality rates during childbirth or before, pre or postpartum periods. And as you know, it's still COVID time, and I am not wearing mask, but I was wearing mask before, and we are 6 feet apart. You'll see my guests soon. I got my 2 vaccines, and I encourage everybody to get their vaccines and to continue to wear a mask and to keep social distancing. Today, my guests are 3 wonderful doctors that I have the pleasure and honor to work with. On my left, we have Dr. Michelle Carson. She's one of the team, also director of our residency program. On my right, I have Dr. Monique Pondy, who's a 3rd-year resident in our program, family medicine. And also over there we have Dr. Elizabeth Alabi, who's an OBGYN and also works with me at Hennepin Health. Welcome, ladies, doctors, and before I get you to introduce yourself, I would like to, I'm gonna share this on my page first, and then I will tag you all later. And also, I want everyone to be able to join this conversation, which is very important. Whether you are a Black woman or not, this is a problem that we all are facing as healthcare providers or just as a community. So we have to talk about it and see what we can do to decrease this issue. Before going any further, I would like also to talk about Bolo's Body Butter. As you know, as always, Bolo's Body Butter is the new skincare line that I created, and it has natural shea butter, cocoa butter, and essential oils. I have different flavors and scents. 10% of the proceeds from Bolo's Body Butter is going towards Childbirth Africa, which is a non-profit organization that I founded that provides health care for women and children in Africa. I just had a new fragrance, new scent that's made out of hibiscus flowers and orange peels. Those are just infused in the oil directly, so they're real, and it took 2 to 3 hours to make them. I added some hibiscus flowers from Africa, and it just created an awesome cream that is a limited edition, so my guests will be going home with each one of them. So I am going to have my guests introduce themselves. Dr. Carson, you go first.
Thank you, Bolo. I'm Dr. Michelle Karsten. I am a physician in family medicine at Hennepin Healthcare. My current role is as the program director for our family medicine residency program. I, am lucky enough to care for women and children as men from all ages, cradle to grave. And one of my particular interests is in healthcare for women before and after, and of course during childbirth and their babies. So I'm delighted. Thank you, Bolo, for inviting me to talk about this and to address this really, important issue of reproductive justice and racial equity in healthcare.
Thank you, Dr. Carson. Welcome. And Monique, Dr. Pandi.
Hi, my name is Monique Pandi. I am a third-year resident at Hennepin County Medical Center. I will be finishing my residency in a couple of months. I also do take care of patients from birth all the way till older age, and one of the things that I'm very passionate about is patient education, women's health, and taking care of pregnant patients.
Thank you, Dr. Pandi. Dr. Alawi?
I am Elizabeth Allaby, and I am currently in my fourth year at Hennepin Hennepin Healthcare now. I am an obstetrician gynecologist and basically take care of women in the full spectrum, so both obstetrics and gynecology. I am very interested and very passionate about racial justice, equity, education, and really just empowering patients to advocate for themselves and the rest of their families.
Thank you very much, Dr. Albi. Yes, as you know, I am a nurse practitioner, and also my goal always was to promote women and children's health. And that's also one of the reasons why I created my nonprofit organization, Childbirth Africa, that provide that same health disparity, to help with health disparities that also is in Africa. The childhood and maternal mortality rates are even higher in Africa, especially in Senegal and around Canal area where we go to. There are numbers of children and women who die every year because of lack of health care access. So this is the same problem we have here in the United States, and many studies and CDC have indicated that black women have 3 to 4 times higher rates of death during childbirth or before than Caucasians. The comparisons are always compared to white women, so there isn't enough comparison to other ethnicities, but they are at 3 to 4%, higher. So, 4 times, 3 to 4 times higher rates of mortality. So today we're going to try to see as healthcare providers what could be the problem. And I know Hennepin Health has some wonderful doctors, and some of them are sitting here with me. And our goal is to try as much as we can to lower that disparity and to find the problem and fix it, to encourage Black women and people who are low income and people who are from different backgrounds and different socioeconomic levels to come forward and get the help that they need and not be afraid to come forward. So our first question here is to ask each one of the doctors, what do they think, what do you think is causes or cause of this high rate of maternal mortality during childhood? During childbirth. Who's going to go first? Okay, we're going to in this order. Dr. Carson.
Thank you, Bolo, for that. I think it's fairly clear from a number of studies and the experts, that race is really the risk factor because of racism. There's no inherent difference between different races. And when you control for different pieces, such as access, such as socioeconomic level, all those things, that it's really the structural racism. It's the inequities within our communities and within our country that lead to these disparities that we see played out over and over again in maternal and childhood morbidity and mortality.
Yeah, that's a great point. And yes, I agree with you that this disparity stems from the fabric of this country, which is racism. And of course, that created many other different issues that led to it. Thank you, Dr. Carson. And Dr. Pandey, what's your thoughts?
To speak more to what Dr. Carson said, I know from my experience when I have women that come to the clinic, a lot of them has mentioned to me that they don't have that experience of seeing a doctor that look like them, and not having that opportunity makes you not only a little fearful of going to see the doctor, but just not trusted. You don't have the opportunity to have that trusting relationship because you just don't think that the doctor that you're going to see is either going to understand what you're going through or is going to take you seriously. And I know that while I was doing my research, just learning more about it, the mention of patient not seeing doctor that look like them or they feel like they will understand what they're going through is a reason why a lot of women are not seeking prenatal care very early on, or are not just going to the doctor as often as they need to get the care that they need.
So, Dr. Pandey, you think it's because because of the lack of trust or they won't have representation, lack of representation, that they don't want to go or they're afraid to go too far. And that I think goes back to what Dr. Carson said, that because they have that prejudice and background of racism, they're afraid to go. If it's not a Black doctor, they're afraid probably something is going to happen based on what happened in the past.
Absolutely.
That's a great point.
Yeah.
How about you, Dr. Alawi?
I think just to piggyback off of kind of what both of them, Dr. Karsten and Dr. Pandey, were talking about, I think in the past we've focused so much on the patient and the genetics and the housing and the education and the socioeconomic status, but I think since the murder of George Floyd, a lot of focus has really changed from just the patient to the individual providers and the institution. And so to piggyback off of representation, our studies go along with, even when women do present to care, they don't get the same quality of care, and why is that? We talk a lot about implicit bias, and so there's so many things, but I think finally the medical system is really taking ownership of our past and our relationship with the Black community, not just Black women, and it's something definitely not taught in medical school, and really looking at ourselves. So what am I doing and how am I operating in this system that's also contributing to the problem? Because there are barriers and policies that we all abide by that are actually contributing to healthcare disparities and inhibiting healthcare equity.
Right.
And to speak to what Dr. Alabi is saying, even when you look at hospitals that are part of community of lower income people, you can tell that the amount of resources that are available to those people is not similar to what we see either in bigger cities or in cities where you have people that have more like higher economic status and they're more affluent, which is another reason why you see that disparity of like, even for the women who are advocating for themselves, who are going to the hospital when they need to and who are following the guideline, if they live in a city or in a community where, you know, the closest OBGYN is like 50 or 60 miles away, it will impact to in their well-being without her having, you know, doing her part. So.
And what hurdles does she have to jump through to get the limited resources that are actually available?
Exactly. Yeah.
That's very true. That's very true. And yes, the socioeconomic status and Dr. Carson talked about history of racism. And your OBGYN, and if you remember how was pelvic exam, how was it learned at the first time? It was with a black woman, right? When they were doing first time, I don't know, pelvic exam or what, pap smear, right? So then that is a history that black people keep hearing from their ancestors. So that whether they have it consciously or unconsciously, that's in the background of saying that I fear going to a doctor's office. I don't want to go to a doctor's office because there's going to be studies done on me. I have a lot of patients who tell me, you guys want to just study on me. You guys just want to have your residents come and learn on me. You know, and they always think there's a hidden agenda, and it's very hard to sometimes keep them comfortable or make them, you know, build that trust to make them understand that was in the past, but now there are a lot of measures that are taken that's not going to happen, you know, at least should not happen. So
there's a long history of experimentation on disadvantaged communities, and in this country, mostly black communities.
Yes.
And it's not that far in the distant past, right? I mean,
they were still sterilizing women in 1979 against their will, and there are like California prisons who were doing sterilizations on women in 2010. So it's like happening now. This is like present day.
Yeah. So there's a ton of mistrust, right? That's not. I mean, this is coming up now with vaccinations. I mean, I'm so glad you mentioned that, but this is not. It's not old news, right? This is ongoing.
Yes, and that's, it's not just about the OB or the women's care, but it's everything. That's why many people in the black communities don't want to take the vaccines because they're afraid that they're going to be sterile, like their kids are going to be sterilized, or it's also experiments that's going to be done on them. So we have to understand that with that background, it's very hard for healthcare providers or systems to come over that. It will require a lot of trust building, it will require a lot of education. And as a faculty, I know that when you went to medical school is different than when Monique, who's your resident, went to medical school, right? So can you tell us, Dr. Carson, what were you taught about these prejudices and unconscious biases in school to pay attention to? And I want to ask that same question to Monique too, and to all of you.
So it's been a long time since I was in medical school.
It doesn't look like it.
No, it has been a long time. I mean, I graduated medical school in 2000. I don't remember being that this was covered at all during my medical school career. So that has been a long time. It's possible that I don't remember, but it was not a large topic of what we talked about, and so no, it wasn't. And you know, we do work on it now within our residency and that sort of thing, but from then, no, that wasn't a piece of my school education.
Yeah, and I feel like, I mean, I'm sure many doctors in different areas went through the same thing, not knowing this is happening, and it's like we talk about unconscious bias. I do certain things probably that if I was white, people may think I am being prejudiced, because this is an unconscious bias that is built in the culture of healthcare, where you may do something without knowing you're doing it. You know, where we didn't have enough self-reflection to say, wait a minute, if I behave or act this way, like let's say somebody says this patient is very, very difficult to deal with. Sometimes automatically you think it's a black guy, right? That's unconscious bias. And even a black person may think that way. Oh, it's probably a black guy, because that's what we are taught. That's what the society is showing, that the black guys are the ones who behave like that. Oh, it's a young black woman. Like if it's OB and they say the patient is doing this, asking for pain medication, constantly asking for pain medication, you constantly think, okay, maybe it's somebody that's, you know. So that's something that's blindsiding all of us. And the fact that you didn't learn it from school, that you know, and I'm glad you come a long way, because you're doing a very good job teaching your residents about cultural diversity and sensitivity, and that was not done before, and that's why we are seeing the difference. We are seeing how great these residents are and how they care. I'm serious. I see how they care and how much they care about diversity, how much they care about health equity.
Yeah. It's a journey though, right? Because it is built into our system, and we are like always having to pay attention, to unlearn it, to question it, and it's not hard. It's hard, right?
Exactly.
It's not easy, right? I mean, we still have, you know, race built into calculators for different, you know, pieces, especially in, you know, the world of obstetrics. We have, you know, for one of the calculators about, you know, what you're going to do if you've had a cesarean section in the past. Like, race is part of that calculator, and it's up to us, I really think, to be like, and especially for white physicians, to question that and say, why is this here? Is this serving our patients, or is this not? Because it doesn't always serve our patients, I don't think.
Just like even piggyback off that, like, so even when implicit bias training does happen, like your everyday experiences far outweigh any training that you're going to have. So you can have training, and it doesn't matter if your training is once a year or every other year. You're taking all of the experiences that you've had for 30 years, 40 years, 50 years, and we're physicians, and how we take care of people are patterns. And so your implicit bias comes into play when you're doing your pattern recognition and treating whatever illness. And so I think, you know, implicit bias is a start, but I think, you know, like Dr. Karsten is saying, it goes even further and deeper than just the training.
Right.
Because our experience and your everyday, you know, bias is going to far outweigh any 1 hour training that you have.
Yes.
And
Exactly.
For me, like, I did not get any of that training. Granted, I went to medical school at Ross University, which is the Caribbean school, so I'm not exactly sure what the U.S. medical school and how they're integrating those like trainings and stuff. But speaking to some of my classmates who did go to U.S. medical school, it doesn't seem like that was something that was part of their curriculum. I think one of the thing that makes me feel fortunate to be part of my program is because not only we serve a diverse group of patients, but the resident and the physician themselves are very diverse. So by being challenged to reflect on your implicit bias when you take care of your patient, you are also able to get some of it when you interact with some of your co-residents, because they can tell you about their own experience, either as being a patient themselves when they were in their country, or just letting you know about like what is acceptable and what is not acceptable as part of their culture. And you know, I've learned a lot about taking care of my Asian patient just because I have Asian residents who are part of my program. And then I would talk to them and say, is that, you know, something that we do in your country? Like, is it just, you know, something like that? Like, one vivid example for it's like in OB and family med, when you take care of women who are pregnant, it is very known that a lot of the Somalian women will rather have a female provider as opposed to a male provider. And sometimes, you know, when that topic come off and the female is vocal about it, sometimes it might come off like, oh my God, she's just being difficult, or like we don't have enough staff to be able to accommodate that. But it's like, is it really accommodating her, or is it really making sure that the patient is heard and the patient is taken care of?
Yes.
You know, but when you are able to speak with your resident, the co-resident who is from Somali or like other country who have very similar culture, they will let you know that no, like in my country, we have the male doctor, but we don't have the male nurses, because that's just what happened. So you will understand, like, oh, okay, it makes more sense that she just wants to be comfortable with what she knows. It's not that she's difficult about it. It's just she doesn't know any different.
Religious, and that's the part that that's the special thing that Hennepin has that many other places don't. Like you said, the staff mostly is diverse, and the patients are diverse, and we learn a lot from each other. You know, like family medicine room, you come in there, you look like you think you are in UN, United Nations, because there's somebody representing every country in the world. And one example, there was a patient who's Somali, older lady who covers her hair, and one day her hair cover was off, and I heard she's like very anxious and doing something. I'm like, go put that hair cover back on right away. That's probably why she's anxious, and that's helpful. That among staff, we know different things that can teach others, and that's a great addition. Thank you all for that wonderful those wonderful contributions. And the other thing is, we talked about the racial issues, and what else can be the barrier for or cause for mortality in Black women, other than the race, like socioeconomy, or what other factors can be there for us to understand that's the reason why maybe this is happening.
Where does it end, I guess? I mean, where do you live is a big part of kind of how a lot of this comes into play. So how much money is pumped into your schools? Do you have stable housing? Do you live in a food desert? Do you have access to care? When you do seek care, are you heard? Are you listened to? Our implicit bias comes in again. You know, you're already forming kind of your stereotype when this patient comes in, and so when she is talking about like her experiences and what she thinks is the problem, do you actually take her seriously? There's just so many issues, you know. And then, you know, family medicine is beautiful, but there's no other department at Hennepin where our providers really reflect the demographic of patient that we're seeing. And so I think that comes into play. I have a lot of patients who seek me out for OBGYN specifically. I can't tell you how many times I hear, Dr. Alibi, I don't want to die. And so at least daily, right? And so just to carry that to weight of like, I'm pregnant and I'm scared I'm not going to make it through a pregnancy. I'm scared someone will let me bleed to death. They will let my baby die. That's not on the patient anymore. Like, that's on us. So.
Exactly, and it's sad that it's sad to say, but when you're a Black woman and you're in a vulnerable position, giving birth or whatever it is, you are viewed as a Black woman. Who cares if you're a doctor or a lawyer or homeless? We've seen a video circulating of a Black doctor who was dying, who had COVID and was in pain and complaining, and nobody took her seriously until she died. And we have Serena Williams, it's her, right? Who had a baby and complained of chest pain, and nobody took her seriously. She has tons of money, you know. Nobody took her seriously, and she had PE, pulmonary embolism. She could have died. So it doesn't matter who you are. You are a Black person. You were there most of the time. Chances are you're not taken seriously, like you said, and that can lead to fatal result. So I want to know, you as providers, and I know who really are aware of those problems and care, what do you do, and what do you do to you, Dr. Carson, who's a faculty teacher, what do you tell to your residents, and how do you build that trust between patient and provider to help them be at ease?
So I think that's important, but I would also say I think the other piece that we do is we really try to recruit and retain residents and physicians of color, and this goes back to biases that are in medical education, biases that are in standardized tests. So, right, like there's a small number of physicians in this country, male and female, who are Black, right, and that's partly because
5%.
of what?
5%.
5%, yeah. It's tiny, right? It's tiny. And, you know, that goes back to housing. It goes back to education. I mean, it goes back to all of these pieces that are all interwoven together because of structural racism in our country, right? And it just feeds into it from different ways. I mean, we are very intentional about our recruitment and our review process for our residency to try to counteract a lot of those biases that are already in the system, right? You know, we blind our reviewers to standardized test results, for example, because we know that there is so much bias built into those tests. We look broadly at the school that our potential residents come from, because we know there's so much bias just to get into medical school. So there's a lot of pieces that go into it, because we also know that if you have race concordant care, like what my colleagues are talking about, Dr. Alabi and Dr. Pandi, there's better outcomes, right? So like that's really important. I mean, you have to be super intentional about bringing, you know, Black and other underrepresented minority physicians to the table.
Yes.
Because if you don't do that, you're not going to be able to have race concordant care, right?
Yes.
So there's all those pieces, and I mean, so we talk about that. We talk about where are these biases built into our system? How do we have to pay attention to it? How do you listen to your patients? How do I listen to my Black patients? I am obviously white, but how can I try to be a better listener? How can I be there and have them trust me as their provider? Because we don't have enough Black doctors out there to take care of all of our Black patients. So how can I build that trust? And so, I mean, and we talk about it. We just try to talk about it really openly, because I think that's, you know, like just step one to approach it.
Yes, and you guys are doing a good job in recruiting residents from every background, that giving them a chance to be representatives of those backgrounds. Thank you. Anything else you wanted to add to that?
Like for me, one of the things that I've been more intentional about doing is not only just focusing on the women, but just all my patient in general, is making sure that when I'm in the clinic with them, I really spend a lot of time on patient education, because there's so many times when I will have a patient come in and they're on this list of like 10, 15 medication. They don't know why they're taking what they're taking and things like that. And I think for a lot of people of African descent, they have the higher population of having the more of a chronic disease and things like that, which also will interfere with their, which will also, which will also interfere with when they become pregnant later on, you know. So
also, for some reason, my Facebook is going live on me.
Residents from.
Okay, sorry.
That's okay. So if you are a woman already who is of childbearing, but you have all these chronic conditions that are not well controlled and taken care of, if and when you become pregnant, it's an other added burden, you know. But so when the patient comes in the clinic, knowing already that, oh, there is potential for her to be pregnant, you know, I spend more time talking about making sure that her other comorbid condition are either taken care of, or at least for that patient to understand how that would affect if anything happened. You know, I talk to them about maybe temporarily putting them on some form of birth control just to make sure that other things are taken care of before she becomes pregnant, because you want to optimize her health when she actually becomes pregnant, to help make sure that, you know, she end up having not only a successful pregnancy, but also that she's able to deliver and have a postpartum care that is successful. As I was reading and getting prepared for the talk, one of the points that was illustrated in some of the articles that we're reading, we're talking about how a lot of the time we we as physicians are focusing on the prenatal and the labor and delivery part. And a lot of the time, some of the morbidity and the mortality that we see is actually during postpartum, because we don't spend a lot of time educating patients about understanding how important it is, whether it's like letting them know about the sign and symptoms of depression that comes, like postpartum blues. And, you know, all we do is like, oh, you come back in 6 weeks, we're going to do your postpartum check, and then that's it. And then sometimes you might have patients that might need to come sooner, that might need to come more frequently. And I think as a provider, it's just changing our practice in that way will be also helpful.
That's very true, Dr. Pandey. I think you're right. Most of the time, those patients have higher comorbidities than average patients. They're either very obese, morbidly obese, or they have underlying chronic conditions such as diabetes or even cardiovascular disease that can make their pregnancy or birth complicated, and that's not taken care of first. And also that stems from the lack of trust, lack of means. Somebody probably doesn't have a babysitter, so I'll miss my appointment. Or I don't have money, I don't have insurance to buy my medication, so I'm not going to follow up with my blood pressure or my diabetes. And that also that socioeconomic differences is all from what we talked about earlier, like racism. So it's just all tangled, and it's just hard to detangle everything and find the true, the source of this, because there's so many factors that are involved. Dr. Alabi, did you want to say something?
No, I think, it's not going to be possible to have, racially congruent care in the next 10 years. And so I think a big part of, at least for us, educating residents and medical students is always asking why. And so one of my biggest pet peeves is what you're talking about is the non-compliant patient. But why are they non-compliant?
Absolutely.
Which is kind of what you're saying. So why aren't they taking their medications? Why aren't they coming to their appointments? Do they actually know what their medical comorbidity means, right? A lot of times people will be like, "Why I was given medication, so I no longer have X, Y, and Z." Right? And so why? Ask your patient why, and then address those issues. And then also looking at the patient and acknowledging what they're not saying, right? You can easily look in Epic or the chart and see their problem list, but like, what is their demeanor when they're sitting in front of you? Are they making eye contact? Are they responding to your questions? Do you feel like you guys are in tune? Are they depressed? Because I think we are not acknowledging there's a really big mental health component to a lot of our patients. They've had very traumatic lives, and you are not going to get someone's blood pressure or their diabetes under control when they don't even have the motivation to take care of themselves. And so I think that is something else, like really teaching your med students and your residents like why, and learning what resources are out there so you can. There's no point in asking somebody why if you're not going to do anything about it. And then also just being okay with the fact that sometimes someone may come in for an issue and you don't deal with that issue because there's another pressing issue. I can't talk to you about your blood pressure when you're homeless. Right? Like, we need to find stable housing for you. And so I think teaching people to think that way is probably going to be the best first step that we can do, I think, as a unit of providers.
Yep, I think you're absolutely right, Dr. Alabi. Taking care of the patient in a holistic way. That's what we learned in nursing. You have to take care of the patient in a holistic way, which means look around the patient, the family dynamic, the macrocosm, what is going on that may affect this patient's care or patient's following up and all of that. So in plus, especially in the Black communities, what I notice, and even in patient, when I take care of some patients that are admitted during or around the period when George Floyd was killed, the anxiety level is high, and that's chronically how it is when somebody is a Black woman, because they're always anxious that their son who's out there may be killed. They're always anxious that their husband may not come back home. and they always afraid to be judged or to be discriminated against when they get out. And that, we all know, that can cause ongoing chronic anxiety, that can cause high blood pressure. That's going to be hard to just lower with medications, because you have to take care of the psychology and take care of the emotions. So this is just, like I said, it's a whole different things that are together that are causing all of this.
Weathering.
Yes.
That's like the term that is
exactly.
used to describe that chronic stress and tension that you just live with in your daily life.
And like you said, you can't just take care of this superficial problem that you see on labs when you don't take care of what caused it, where it came from. Somebody is homeless. They don't care about medications or going to see a doctor if they worried about where to sleep in the cold. So we have all of that, and that goes back to socioeconomic and all of that. So great contributions. And my next question to you is, like, if you're looking at a black woman right now who is hesitant to go see a doctor or who had a bad experience, what would you tell them as a provider? What would you tell this black woman who's saying, I don't want to die, I don't want to bleed to death, I'm pregnant, I don't want to bleed to death when I go to the doctor or when I go to deliver, or I'm afraid to go to see this doctor who's not black? What would you tell them?
What would I tell them? I think that you could start with, if they could find someone they trust who has someone that they trust, right? So, like, just so that you would have like a base of, like, maybe entering that in with some hope that you would be able to build a trusting relationship, right? Because I think that means a lot, right? If you have someone that you believe in, this is like, no, listen, I saw this person, they took good care of me, I think that goes a long ways. And then you can start from there, because, otherwise that's a really hard place to be in.
Yes. Yes.
But I would love to hear what you guys say.
Thank you.
Like, seriously, really. Because that's really hard.
It is very hard. I think for me, like, the 2.5 years of practicing that I've done, I think what has struck to me is that patient recognize when you care. Right. When you are in the room with them, like, you're making eye contact and you're really listening and you're giving them feedback based on what they're saying, as opposed to just this mental script that you have in your mind and just going through and checking the boxes. I think a lot of the time the patient recognize that, and you can use that as a way to draw them more in. Like, it makes a difference when the patient is in the room with you and it's like, oh, like, this person actually listened to what I was saying. I think that, and I think a lot of the time what we consider as a quote-unquote successful visit might not be necessarily what the patient considers successful visit. I know for us, as part of our training, we're really big about agenda setting. And then even if, you have all these things like, oh, I have to do this, talk to the patient about this and talk to the patient about this, making sure that when the patient comes in, you actually say, this is what I want to talk about. I'm sure you have other things to talk about. Let's come to common ground and figure out part of my, agenda that I have and part of your agenda. Maybe we can come to a middle ground at some point. I think having to practice that and make the patient feel like you actually pay attention and you care more about hearing what they have to say, as opposed to just dumping more information on them and moving on to the next one. So.
Yes, I think that's perfect. I think finding someone that you trust who has found someone that they trust. I think also, coming in there with questions is a really good start. And then again, I think providers also acknowledging what's important. So you have this problem, but, like, ultimately, what is your end goal? Like, what do you want? And then using that to really tailor your visit. And I think also our tendency is to, like, talk at people instead of have, like, a conversation with people. And I think that's a big part of it. And I think just expectation. So a patient may expect something, but that actually may not be appropriate care, but I Googled it. This is what my cousin was doing. My sister said this. And so that comes back to like the education, the education piece of it. And I think when patients trust you, which for us, I think part of that healthcare equity is meeting people where they are. It means we are going to have to go the extra steps. So does that mean that you're going to have to Google something on the internet and show somebody what this means and really educate the person so that when their cousin or their aunt or their mom says, but this, they can be like, but actually, it's actually this. And I have this provider, and we talked about it. I see a lot of like moms and daughters, sisters. I take care of whole families now. But a lot of it, there's so much breakdown of like, that's actually not true. And I know you read that on the internet, but that could have been like some 14-year-old at home. Like there's, who's just bored and decided to make a list or write something on the internet. And so I think what I tell women is like, you're going to have to be your best advocate. And that means you're going to have to come in there with questions and try to educate yourself as much as possible, and then find someone who you just feel comfortable with.
And that someone can be white, can be black, can be Asian. Because I've seen a lot of people who are black and had issues with black doctors. Or nurses, because they feel like, I don't know why these people for some reason they feel like those people are trying to prove that they are bad patients or something. And I have patients who have white doctors who they love and adore. So like Dr. Carson said, it just depends on your approach. Whoever you are, whoever the patient is, it depends on your first encounter. When you meet the patient the first time, the way you treat them, the way you interact with them, that's what they're going to take home, and that's what they're going to remember for the next time. Me personally, I like to build the trust the first time I meet the patient. I had a patient who told me this is a patient who's just dependent, like total dependent, but can't talk. Who after I explained, this is why we're doing this, sitting down and explaining, he looked at me. He said, "You are one of the good ones." I was like, "What does it mean?" He was like, "I just see the compassion in your eyes. I know that you're really, really genuinely looking out for me." And that just made my day. I'm like, even if I wasn't paid today. But it's very important. It's very important that first time, I don't care what you hear outside of the room, like somebody may say this is a difficult patient, don't go with that. Go with a clean slate and try to build that relationship. You'll see the difference. You'll see that people just want to be listened to. People want to be treated as humans, like you said. Don't talk down, talk at the same level and talk to them, with respect and answer their questions and correct them if they're using Dr. Google to have you to do things that should not be done. And they know that you're genuinely looking out and you're not looking at your clock and trying to just move on to the next one. So I think it doesn't matter if the doctor is black or white or Asian. They can build relationship with the black patients that are troubled with the healthcare.
And I think we have a responsibility to also challenge the people who are giving labels. So when you hear the term, well, this is a difficult patient, why are they difficult? Why is a perfect?
Exactly.
But if they're going to label that person before you've seen them, why are they labeling said person? Like, have they also done their own work into taking care of this patient? Because I think we have to call each other out too when we see it.
Exactly. That's a great conversation. And you viewers, if you have any questions, please put them on our comments, or if you want to join the conversation, there's a number on the screen you can call, or we would love to hear from you. So anything else you want to add?
I mean,
one thing that I wanted to ask you guys, pain management. That's a whole different thing as well. I have, like I said, this implicit bias is affect everybody, regardless of who you are. When you work in the healthcare, you may fall into it without even knowing. We can have sometimes patients that are screaming in pain and crabby and yelling at nurses, yelling at everybody. And to me, I have sometimes to sit down and think and say, I think maybe they are in pain. This is more than just seeking. I'm going to throw in everything I can to see if that's going to help. And sometimes you do that and you come back, they said, I'm feeling much better. You know, and that's an issue that we have with Black patients. It's always, and we saw that example of this doctor, that poor thing died. She was in pain and kept asking, and one doctor was telling her, I'm not prescribing any more narcotics, or I'm not giving you any IV narcotics. You know, I mean, that's just wrong. Pain is very subjective, you know, even if we know somebody has a background of abuse, but if they are constantly crying, they're in pain, let's do something and see. Or let's look at something, maybe they have PE, you know, with Serena Williams. Maybe there is a reason, because this lady, they wouldn't do any test on her. They wouldn't do any scanning. She has to go up and down, or even maybe change hospital for somebody to do a scan and find out that her lungs were messed up. So any advice, anything we can do, or anything we can tell patients, if that's the case, if you are a patient and you are in pain and you feel like nobody is listening to you, what should you do?
Ask to speak to someone else. So if you feel like your nurse is not listening, ask to speak to the charge nurse. And if you feel like the charge nurse isn't listening, you ask to speak to the doctor. And if that person's not listening, then, you know, there's patient reps. And so you just keep ascending kind of the chain of command, right, until someone listens. And it's really hard right now with COVID, but your support person can also be an advocate for you.
Thank you, Dr. Alavi.
Yeah.
What do you think?
I think that for us, like as far as like the physician, one of the things that I'm learning is that not only that pain is subjective, but pain can come in different phases. You know, like there's the physical pain, but it's also the mental pain that come into play. We talked about like an example of a patient who is depressed. We know that patients who are not mentally stable have a lower tolerance to like anything discomfort level, you know. So yes, you might want to give them the medication to help or whatever, but I think also taking the time to understand why is it that, you know, the Tylenol that you just gave them didn't work. Maybe they don't need the Tylenol. Maybe they need, you know, an antidepressant to kind of help with that. So I think not just going quickly to like, oh, I'm just going to throw a medication at you just because I want you to shut up. Like go back and understand and be like, why is, you know, your pain is like that? Is there anything else that is contributing? Are you actually hungry because you didn't eat the food that, you know, was at dinner because you don't, it's not something that you eat usually? Or like, do you need a shower? You know, like little things that contribute to pain that we tend not to really think about on a daily basis. I think just having that mindset is also helping take care of the patient in a better way.
That is
anxiety and fear.
I was just like, sometimes patients are just scared.
They're
just like so frightened that they have something that's dangerous. Right? Like I can't tell you how many times I'm like, oh, they want pain meds. And like, no, truly, the patient just wants to know that they don't have something that's dangerous. Like that's it. You can reassure them that they don't have something dangerous.
Reassure
and like truly so like so much I feel like it's listening and hearing the patient's story and trying to find out what's really going on.
I think sometimes we don't really utilize our ancillary services to the greatest capacity. I think whatever it is, whether it's like therapy or psychology or physical therapy, we deal with a lot of like chronic pelvic pain. There's not chronic pelvic pain from the 20-year history of like sexual assault that nobody in the family knows about, right? And it comes across as like I'm always in pain. Well, there's no medication that I'm going to give to you that's going to fix this. Like we need to, there's like an organic issue that we have not even began to like dissect here. And so I think that's like another approach. And I think people sometimes aren't even aware. That's the other thing. Emotional intelligence is something that as a society we really need to work on.
Yes, that's absolutely true. Difference between providers is the levels of emotional intelligence, like being able to read the patient and like looking at the bigger picture and saying, okay, what else do we have here? Like you said, nobody will ever just think about out of the box, oh, your pelvic pain is because you were raped when you were a child.
You have to ask.
You know,
right?
Yeah, dig it and ask questions and find it.
Yeah.
That's a great point. That's a great point. And I think we are almost at the end of our hour. It's a great discussion. It's very interesting and great inputs from all of you. And I hope that people who are listening are learning something from this and are being encouraged to always discuss with your doctor or nurse practitioner or whoever is your provider. We are doing our best to listen and to change the healthcare culture and dynamic. And like Dr. Alabi said, if you are not listened to, you can always escalate. Don't limit yourself to the nurse that you're interacting with. You can ask to talk to the doctor. If the doctor is not taking care of it, we have the unit manager, we have the patient representative that is here for the patient to address issues that you have. You can also have your family member come and call to advocate for you. So there are all different ways to help you, and also making sure you follow your instructions, going back to your appointments and taking medications as directed, or if you have questions or fears, ask. And always get education because it's there for you and you have the right to it.
Right.
Absolutely. Anything else?
No. It's our job to make sure that you understand, so
Yeah.
that's our job.
Yeah, and I hope you learn from these wonderful and knowledgeable doctors. And I'm so glad that you guys are doing what you're doing. And I know that you are up to changing the culture and getting something good out of it. And also mostly, and the most important thing is to have diversity and representation. And like Dr. Carson said, they are trying to do that as much as possible. But also, I think it starts off with schooling, like from elementary. Let's encourage the kids to have good school, better schooling, because better schooling will define the future. If a child who's black or Asian or whatever wants to go to medical school, let's encourage them. We need more kids. We need more young people interested in the medical field so we can get diversity and help change this culture. Thank you so much, and I'm going to go back to the Bolo's Body Butter. We can't miss that. So, like I said, I have this brand new Bolo's Body Butter that's just made 2 days ago. It's hibiscus flowers and orange peels. They were all soaked and double boiled in the shea butter for hours and to produce this baby. And it's very highly moisturizing. If you don't know what shea butter, hibiscus leaves do or flowers do, Google them. There are so many vitamins and things that are good for your skin. And every time somebody buys Bolo's Body Butter, 10% of it is going towards women's health in Senegal, women and children's health in Senegal. Believe me or not, we have that problem there too. And these are going home with my wonderful guests.
Thank you.
Thank you.
Thank you, Bolo.
So thank you all for being with me today. And we do this show once a month. Like I said, we talk about social injustice that can affect public health. We talk about health and wellness, talk about topics in the healthcare that should be issues that should be changed. If you have any topic that you would like to discuss or to bring here, or if you would like to be our guest, please let me know and we'll do that. It's a monthly show. Thank you so much. Dr. Carson, thank you so much. I'm pleased to have you, very honored. Thank you so much for everything that you're doing outside of here and for our residents. Dr. Pandi, you're going to be a great doctor.
Thank you for having me.
I don't know where she's going to end up, but you have a great family medicine doctor if you have her.
Thank you, I appreciate it.
And Dr. Alavi, I'm sure her schedule is very full. So if you want to fit in there, go to Hennepin Health and ask for Alavi if you're having a baby or if you want to have a baby. Thank you so much, you all, and I'll see you soon. Thank you.
Good. Oh, okay. Well.
My whole life, my father told me stories about moving to the United States. He would tell me that his brother, my Uncle George, was already living here and let my father stay with him for a while. Through my Uncle George, my father was introduced to our cultural organization here in America, who helped him make connections, apply for college, find his first job, and adjust to life in a completely different culture than he was used to. The Cultural Association helped him get started on his new life. My Uncle George would bring my father with him to the annual Summer Cultural Groups Festival, and later, he would bring me. It was incredible to see so many people of all ages laughing and celebrating with food and song and dance. It brought back the best feelings of home and gave my father the opportunity to pass his culture, language, and values on to me. My father and Uncle George were very close, so when George died last year, my father wanted to honor his wishes to be buried with a traditional ceremony back at his birthplace. My father told me that because Uncle George had cultural group life insurance, he was able to afford to bring George home and have the traditional burial George wanted. Though my father had been able to honor my Uncle George's wishes, it got me thinking about my own family. One day, I'd have to make the same arrangements for my own parents and my wife's parents as well. Of course, we would want to bring them home and honor their wishes, but it would be a financial hardship for our family. There were a lot of things to think about, even though I really didn't want to think about them at all. When my father told me about cultural group life insurance, he told me it's intended to help families when they need it the most. It's not tied to an employer, so no matter where my career takes me, I'll always have coverage. The more people who participate and the younger they are, the more it helps keep the insurance premiums down for the entire association. Because my parents have cultural group term life insurance, there will be money available to help me provide the kind of service I want to give my parents. And by joining, I can put my mind at ease and continue to celebrate our traditions into the future. With cultural group life insurance, I can worry less and spend more of my time celebrating with the people who matter most to me.